lot of different ways to explain this to patients. You'll probably have to have a few strategies, because the way that you think makes sense might not make sense to your patient. Most of the time, we say something like, what I want you to do is bear down really hard. And almost always, I will show the patient. Say, I want you to take a deep breath, and then bear down like this. So see how my face is getting red, kind of veins maybe popping out? That's what I want to happen. We need to actually have a decent amount of pressure in your body when we're doing this. That's how I explain it almost all the time, and most of the time patients understand. Occasionally I have a patient that won't have a clue. Sometimes I say, I want you to bear down like you're having a bowel movement, but rarely, because I think for a lot of people that can mean a lot of different things. Some people don't bear down. Some people have, diarrhea 3 times a day. Some people go once a week and think that's normal. So I don't necessarily say that, although a lot of clinicians do. When I first started teaching here, it was really funny, so I have to share this with you. One of the other instructors that I never even knew used to make the students remember a script, and it went like this. Now I want you to bear down like you're having a bowel movement, but don't. I thought, are you kidding me? I mean, if they have fecal incontinence, chances are it doesn't matter what you're saying. And if they really think they have to go right there, then maybe you're not the right provider. Maybe they need some psychological help, or you mistakenly are working with a monkey or something. So, and then the other one, which I have heard sometimes, and I think this is equally as weird, is I want you to bear down like you're having a bowel movement, but don't worry, you won't have it. Yeah. Okay. So I wouldn't necessarily say that, and in fact, I stopped saying I want you to bear down like you're having a bowel movement, because just about 50% of the time, people would be like, what? And then the other thing to pay attention to is even after I show them, sometimes they just do this, like. You're just gritting your teeth, aren't you? And they're like, yeah, I don't know what you mean. So you have to make sure that their face is like they have pressure, because that's what this test is. We're increasing essentially our body pressure, which increases intradural pressure. And if we have an increased pressure in the dura, in the space between the dura and the spinal cord, then we're going to potentially increase symptoms of a disc herniation, something pressing on a nerve root, whether it's a disc or otherwise, an osteophyte, something like that, or nerve root irritation. Because remember, the dura goes all the way out to the nerve roots. If this were the nerve root, the dura goes all the way out to the end. So if we increase the pressure in between the dura and the nervous tissue, it's going to increase all the way out to the nerve root. Past that, it's not going to do anything. So bear down. That's all. There's a triad of coughing, sneezing, bearing down that I want you to look up. It's actually a question in your midterm, which is a take-home. So that would be more of a history kind of type of thing. You ask the patient, do these symptoms increase or do they come about when you cough, sneeze, or bear down, like you're having a bowel movement? They might say no, but then during the physical exam, you still do Valsalva, because they might have those symptoms right then and there. So that makes sense to everybody. Sometimes you tell a patient, you make something up, like, what I want you to do is pretend your hand's like an iron balloon and blow it up. But I don't want any air to come out, because they'll do this. That's not doing anything. That's just putting your thumb in your mouth after you had it on my dirty exam table. So it's the blowing out, but nothing's coming out kind of thing. It's the closing the epiglottis. It's increasing the pressure. And that's what you have to convey to your patient. So most of the time I just say, I want you to bear down. 99% of the time, I have to show them before they really understand what's going on. Like, I want veins popping out if possible. Now again, there's a caveat there. If they have severe hypertension or something like that, or history of a stroke, you have to be careful. But then again, you'd have to be careful with a lot of these cervical exams. So let's do Hoffman's, spinous percussion in the cervical spine, and Valsalva.